Hi, everyone. My name is Ron Blankstein. I'm a professor of medicine and radiology at Harvard Medical School and director of cardiac CT at Brigham and Women's Hospital, where I am also a senior preventive cardiologist. It's my pleasure to kick off this webinar. This is a part 2 webinar, and our webinar is on applying HeartFlow next generation plaque insights in your practice. We all know that plaque analysis is a technique that's dramatically expanding, dramatically changing in front of our eyes, and we're all trying to figure out how to best use it. There's data showing that plaque analysis significantly improves risk assessment, so it allows us to identify who are our patients who are at highest risk. But we also know, and this was covered on the prior webinar, that it has direct implications on how we treat our patients. So specifically in the DECIDE registry, it was observed that when information from plaque analysis is provided to clinicians, this results in a significant change in management. And this is on top of the regular coronary CTA read. So after we have the results of the coronary CTA, if we know how much plaque our patients have and what type of plaque, that leads to important changes in medical therapy. In the DECIDE registry, this was in over 2/3 of the patients, there was a change in treatment after plaque analysis information was available. So this webinar is at a very important time in the field, and that is because HeartFlow recently introduced a new plaque analysis, which is the next generation plaque analysis, and the cases featured on today's webinar are going to use that. And of course, we all know that it's best to learn from cases, which is how we're going to structure this webinar. So without further delay, we're going to get started. And our very first speaker will be Dr. Wesley O'Neill, who's a non-invasive cardiologist, the medical director of cardiac CT and nuclear cardiology at Cone Health Heart and Vascular Center in Greensboro, North Carolina. Wesley, the slides are up, and we are looking forward to your talk. We are, just to remind folks, what we're going to do is during these cases, at the end of every case, we're going to pause where there's going to be time for Q&A. I will ask some questions for each case. I'm really looking forward to reviewing these cases with you. And when we're all done, we're also going to have a Q&A session as well. So please remember to put your questions in the chat. We will try to answer as many of them as possible.
All right, thanks, Dr. Blankstein. And as Dr. Blankstein said, we're going to discuss how our sites incorporated the plaque analysis into routine clinical care. And this is a case-based discussion. I'll start with case 1. This was a 51-year-old male seen by me in the office with symptoms of chest tightness with activity. I did refer him for coronary CTA. His vital signs are shown here, which are normal. His BMI was 27. His medical history was significant for hyperlipidemia, and he was a former tobacco abuser. He smoked for about 15 pack years and had quit 5 years previously. He also had a strong family history. Family of a paternal grandfather had an MI at 57. And here's his lipids shown: a total cholesterol of 240, HDL 61, LDL 163, and triglycerides 94. He actually was on atorvastatin 10 milligrams daily in addition to Pepsid. And interestingly, he had a coronary calcium score the year prior, which was a value of 149 in the 91st percentile. So these are the results of his coronary CTA. It was interpreted as CAD-RADS1. All stenoses identified were less than 25%. And the CPRs of his analysis are shown here. You can see in the LAD, he just had minimal plaque in the proximal segment. He had minimal plaque in the proximate circumflex, and then minimal, basically non-calcified plaque in a large, in a non-dominant RCA. So this is what the HeartFlow next generation plaque analysis does look like. Dr. Parikh will go into that further on how it looks from an interactive standpoint, but this is kind of the overview you do get with the software. You get a total plaque summary, and for this patient, he had a plaque volume of 213. It gives you a breakdown of calcified, non-calcified plaque. And it always is interesting that the younger patients, or patients in general, do have a tremendous amount of non-calcified plaque. Nearly 78% of his plaque was non-calcified, and you do get low attenuation plaque scoring as well, but only 1% of his plaque was low attenuation. You can see here, it shows you the spider view. You can see exactly the vessels where the plaque is, kind of in diagram format. And you can see that he had most of his plaque in the LAD, which is worrisome, especially in that proximal location. But you're also able to see where his plaque was in the circumflex and in that non-dominant RCA. So this is just a screenshot of the next generation plaque analysis from Heartflow. Again, Dr. Parikh will go into a little more detail of the interactive model and how that incorporates and how that looks for you as a user. But basically, just to reiterate for this patient, he had a total plaque volume of 213, which actually put him in the 63rd percentile. But you can actually scroll through, which Dr. Parikh will show. You can see where the plaque makeup is in the vessel. You can actually overlay the FFRCT on it as well. This was not ordered for this patient in clinical care, but just for demonstration purposes, it was available, which was all negative. But you can see exactly where it is. You can see stenosis severity. It's incorporated the roadmap analysis software into it. And all these tools can be overlaid in a more meaningful way for the user to look at the information. But again, here, the screenshot does show that LAD, which was where most of the plaque was. You're able to get a calcified, non-calcified plaque and low attenuation plaque score by vessel territory as well, but it's very interactive, which will be shown a little later in the webinar. This just shows you the circumflex. Again, you're going to have total plaque volume here, percentile score, and then you can see and scroll through the vessel, again shown later, what that plaque makeup looks like circumferentially and what it looks like diagrammatically in a more meaningful way. This is the framework from the DECIDE registry, which our site is participating in currently. And this just gives a staging algorithm as well as treatment algorithm for patients with the plaque volume obtained from the Heartflow tool. And just to walk you through this, it really is going to aid in how you relay treatment decisions to referring physicians, or even if you're a clinician who treats patients, you can get a lot of information from this DECIDE registry, which is now published. This was a consensus document discussed in the last webinar from preventive cardiologists as well as coronary CTA experts, and it really helped to develop this medical management framework. What it does is it walks you through the staging of the plaque score that you get from the Heartflow tool, mild, moderate, severe, extensive. It's going to give you that score of plaque, which puts you in that category. It's going to give you lipid biomarker goals and thresholds for which you should aim for these patients in these categories. It's also going to allow you to risk enhance or use the nomogram. If it's accelerated or above the 50th percentile, you may want to up classify a patient, for example, which we'll talk about with this one, meaning if you're in the mild range but above the 50th percentile, it can really help you up classify someone to treat them in that moderate range. And then it's going to give you a treatment algorithm, how to get to that lipid threshold. And it's really nice for referring docs at our site, as well as even primary care physicians, to look at this and to really know how best to treat their patients from a preventive standpoint from the information from the plaque tool. So just to kind of summarize this patient and how he was managed using that framework from the DECIDE registry, the overall interpretation of the coronary CTA was non-obstructive CAD, CAD-RADS 1. All stenoses shown were less than 25%. He had moderate plaque volume, and it was 213. His actually percentile was the 67th. I do apologize, that is an error. And most of his plaque was actually non-calcified, which is very interesting. And what we're seeing when we use this tool, that really the calcified plaque is the tip of the iceberg. An LPA was ordered for this patient, which was marginally elevated. And then an LDL goal was given for this patient of less than 55 milligrams per deciliter. Moderate plaque, we treated him in that range because he was above the 50th percentile. And then we did add aspirin to his regimen and started him on Lipitor 40 milligrams daily. He actually had a recheck on lipids, and his LDL was still above threshold goal at 90, so he was referred for PCSK9 inhibitor therapy. But really, this case walks you through, from a good preventive approach, how to apply the risk score that you get from the plaque analysis, and how to use the information from the DECIDE registry to really tailor your preventive approach for the patients that you'll see from the next generation algorithm.
Great, Wes. Thanks for walking us through it. Really nice case. I mean, a fairly young guy, family history, smoker. Actually had a calcium score, but not much was done because his LDL was still high. And we see this everywhere, that sometimes either the results are not communicated, or patients or clinicians don't really think much of it. They say, oh, some calcifications in the coronaries. What do you think was the added value here of the plaque analysis? Like, why do you think that led to more changes in treatment than would have been implemented otherwise?
Yeah, I really think with this patient, the treatment algorithm is so clear cut on what to do. I think sometimes we get calcium scores. You could have accelerated above 75th percentile with those, and we try to tailor therapy the best we can, but it's really not clear cut and really not clear with what to do with patients. So I think giving all that information to the clinician referring docs is really going to make it easier to apply some of these preventive approaches that probably haven't been done in a meaningful way in the past based on calcium scoring alone.
Okay, so having a treatment algorithm is important because it's not just here's the results, here's how much plaque your patient has, but here's what you want to do about it. And I think that is really important. We've learned that the hard way, I think, early in the years of coronary CT and cardiac CT, that not providing information and leaving that door open to anything often results in under treatment. I think one of the impressive things in this case is 78% of the plaque was non-calcified, especially for a young person. Tell us how you think about that particular parameter when you're talking to your referring clinicians or guiding your own patients. How do you use that non-calcified plaque data?
Yeah, I think that's the most important thing. I mean, I think we know that the calcified plaque is stable and the non-calcified plaque can potentially become unstable and result in future events. So I really think, this case exemplifies that. The calcium score is the tip of the iceberg. There's so much plaque that we need to treat, but we don't necessarily, one, know how to quantitate it before now, but also how to treat it. So I think that's the most important piece to the puzzle with the cases like this, because I always worry about the calcium score of 0, even though it is low predictive profile. Is there non-calcified plaque we're missing? So I think that's the key to this analysis and this parameter, and really tailoring treatment in a more meaningful way.
No, I think that's a great point. I like to remind my patients that it's the non-calcified plaque that we're trying to modify. That calcified plaque is not going anywhere. So that's really the target that we're trying to treat and hopefully reduce over time. So that's a great point. We do have a question from one of the attendees asking whether you use plaque analysis on every patient, and if not, like what are the cases that you feel like may benefit the most from it?
Well, I truly do believe all patients with a CTA can benefit from it. However, we are limited with reimbursement. So where we've fallen is we do follow kind of what CMS set for CAD-RADS 1 to 3 is when we will order it, and if plaque is seen in those cases. So that's kind of what our institution is doing to fall in line with reimbursement purposes. However, I kind of disagree with that, with the verdict on that. I think all patients do benefit from it, but that's what our institution does.
Okay. And let's say a plaque analysis is done. How do you convey those results to patients and clinicians? Do you do an addendum to the report? Do you do a separate report for plaque analysis? Do you ever show pictures to patients in your office? Tell us how you kind of handle that, both as a clinician and as an imager.
Yeah, I think the nice thing about the Heartflow tool is there are PDFs that you can actually print off, and that can be FFRCT or plaque analysis, and you can really show them and talk with them. It does get put into our reports as part of Decide Registry. It did go in. Now that it's going to be a commercial product, there's a separate report as well. But that does get communicated to the patient and the referring doc. And I pull up the Heartflow analysis when I'm counseling patients in the office, and it's really nice to kind of walk them through it, show them what we're seeing, and really kind of have a more meaningful discussion with a patient about what their plaque makeup is and where it is. Especially in this patient who had proximal LAD plaque, although non-obstructive. So that's how it's done at our site.
Okay, great. Good. Well, good case. Someone was despite risk factors, undertreated, and now you're showing us lots of plaque, high percentile, lots of non-calcified plaque, and ultimately led to treatment was atorvastatin, and then LDL remains high, and now it sounds like PCSK9 is going to be the next agent for this patient, and also aspirin. So medical therapy in this patient was implemented in an aggressive way. So with that, why don't we go to your second case?
All right. All right. So this is case Case two, this was a 72-year-old female with symptoms of shortness of breath, actually referred for coronary CTA. This case is interesting because this case was ordered, or this CTA was ordered through our primary care pathway at our site, where primary care physicians actually can take some ownership and order this test as well. Just shown here, the vital signs, fairly normal, blood pressure slightly elevated for a diabetic, heart rate 89 and BMI 40, an obese patient. History is significant for diabetes, hypertension, hyperlipidemia, and obesity, kind of the standard milieu for CAD risk factors. Family history, MI, and mother and father. And the labs, total cholesterol 200, HDL 50, LDL 117, and triglycerides 190, not at goal for a diabetic. And the A1C was 7.5. The medications for this patient are shown below: aspirin 81, atorvastatin 40, irbesartan, insulin as well, 40 units of long-acting at night, dapagliflozin 10 milligrams daily, and metformin 100 milligrams twice daily. No prior chest imaging. We tend to use that a lot, especially for referring docs from our, we want to know if there's calcium or not, or how much there potentially is for CTA. But we don't always have that information, and this patient had not had a prior calcium score. So here are the results of this patient's coronary CTA analysis. It was interpreted as CAD-RADS 3. If shown here in the LAD in this curved planar reformatted image, you do see there is a moderate 50 to 69% stenosis in the LAD in the proximal to mid segment. But you can just see the LAD is diffusely diseased with calcified and non-calcified plaque. The circumflex minimal non-calcified plaque was seen less than 25%, and in the RCA, really no significant plaque was identified, or all stenoses were less than 25%. So the case really here, the LAD highlights really diffusely diseased vessel with moderate stenosis in the proximal to mid segment. This case was sent for FFRCT analysis, and it does show you that prox to mid LAD is negative. Actually, 0.93 was the value there. There was some tapering as you go down the vessel, down to 0.79, but no meaningful stenosis in the distal vessel. That's just tapering artifact that we commonly see with the FFRCT analysis. Again, this is what you get from the plaque analysis overview. You'll get a total plaque score for this patient, which is what we got, of 535. A lot of calcified plaque, 199 millimeters cubed, which was 37% of the total plaque volume, but a tremendous amount of non-calcified plaque, 63% or 336 millimeters cubed. And then you're able to see where the distribution and makeup in a diagram format from the spider view for the analysis. And it shows you that most of the plaque is in the LAD, minimal stuff in the RCA, and nothing significant in the circumflex. Again, this is a screenshot of the next generation plaque analysis software from Heartflow. Again, you're able to see in a more meaningful way, scroll up and down the vessel, see where the plaque is, the calcified plaque, non-calcified plaque, in a great diagram format. It's color-coded, it's easy to use. You can overlay the FFRCT. It's just really user-friendly to see what you need to see. And even as Dr. Blankstein pointed out, when counseling patients in the office, you can pull this up and show them in a more meaningful way what you're seeing on the clinical side of things. This patient did have plaque. Their total plaque was 535, which is the 90th percentile for this patient. And again, that's a total plaque percentile, but that's helpful when we think about treatment algorithms, especially with the DECIDE treatment algorithm, which I've shown previously. Again, here you can just see the LAD makeup, total plaque volume, calcified, non-calcified by vessel. This shows the circumflex. Again, you can scroll through the vessel, see where it is. Again, mainly the plaque was in the left main for this patient, but you can scroll through the vessel and see where any plaque potentially is by vessel. And then this just shows the RCA as well. Again, you can scroll through, you're able to see that. And Dr. Parikh will show that in a more meaningful way later on in the webinar. So back to the DECIDE registry again, it gives you a nice staging algorithm. Again, this patient's in the severe range, but this patient also is above the 50th percentile. So you're really able to see, you would treat this patient with extensive plaque, or their treatment algorithm or their goals or their thresholds for LDL reduction should be in that range. And it really gives you kind of a really nice algorithm to follow to help get that patient to goal. So just to summarize this case, non-obstructive CAD when FFRCT analysis was done, it was CAD-RADS3 with moderate disease in the proximate LAD. FFRCT was negative. Severe plaque volume, 535 millimeters cubed, but again, 95th percentile, very high risk or accelerated. Most of the plaque, again, just like case one, was non-calcified plaque, 63%, 37 calcified, and no low attenuation plaque here. You know, the LDL goal for someone in that extensive range, given that it's above the 50th percentile in that severe range, we treat them in that category, was less than 50. So this patient was not at goal despite being on high intensity statin, and it was actually directly referred for PCSK9 inhibitor therapy. And actually that patient got the goal very quickly with an LDL of 23 milligrams deciliter. Vascepa was also added to this patient, which I think is important, really tailoring the preventive therapies for this patient, seeing that the lipids are definitely not a goal and triglycerides aren't a goal as well. And that's also in the algorithm for the DECIDE registry, which really goes beyond just LDL reduction. It gives you pointers or recommendations for non LDL reducing agents as well. And that was added for this patient. It also gives you some guidance on GLP-1 agonists. Maybe you should intensify therapy. We know those have cardiovascular benefits. And actually this patient, that was added to that patient as well, semaglutide. So I really think this case highlights, because this patient came from the primary care pathway, we were able to work with that primary care physician to say, hey, this is where the goal should be. And that's another highlight of the DECIDE registry and this plaque tool, as well as the treatment algorithm. It can be communicated to referring docs, even primary care physicians, to help get patients at goal. This patient was co-managed between cardiology and primary care, but really it takes all of those partners or providers to get the patients where they need to be. And I think this highlights the great aspect of the DECIDE registry and what's come out of it, as well as this case example here.
Great, Wes. Well, really, really nice case. I mean, beautiful images, but also really nice example of plaque analysis and FFRCT, moderate lesion in LAD in this case. Certainly one I was looking at, I was saying, yeah, that is a lesion I would have a hard time figuring out whether it's flow limiting, so the FFRCT helpful in the plaque. But I think when you get this information, this is a lot. It's a high amount of plaque, 535 cubic millimeters, putting this patient at, I think it was around the 90th percentile. So this is someone that we have to be really concerned about. And one of the points you made that I really like is that it really takes kind of all partners to put a team for this patient, because it's no longer just about LDL lowering. Okay, let's get the LDL. You did a great job, you and your colleagues. It was PCSK9 inhibitor getting the LDL to the 20s. But when we see a patient like this, overweight, diabetes, certainly we have elevated triglycerides, thinking about antiplatelets, thinking about aggressive blood pressure lowering, adding in this case Vascepa, adding a GLP-1 receptor agonist. It was a diabetics, presumably maybe Ozempic. I think it's important. So the era in the past, it used to be in cardiology, we said, well, we do imaging to see who needs to be on a stent, and we have so many other therapies. And the challenge when you get the scan result back is you have a lot to do. You have to do to get all these implemented. So again, that point that it takes all the partners to get this right, between the GLP-1 receptor agonist, the blood pressure, the LDL lowering. How do you, when you get this information and you're trying to now coordinate this with primary care doctors, how do you make that decision? How do you bring everyone together? Do you say, listen, this is a patient who had a large amount of plaque, we are concerned, here are all the therapies we need to start? Or do you say, okay, I'm a cardiologist, I'll take care of the lipids, and you ask the primary care doctor to address perhaps the GLP-1 receptor agonist? How do you divide all the work that needs to happen when a patient is at such high risk and has a large amount of plaque?
Yeah, that's a great question. It depends on who you may see in our practice. We do have some cardiologists who are actually prescribing GLP-1 agonists. I'm specifically not. I do communicate directly with the primary care providers and say, even the patient, hey, this is a medication you should think about and would benefit from you. We may reach out. Our health system is integrated, so we do have a lot of primary care docs who are easy to get in touch with. So that's something we've worked on. And then even when we've rolled out kind of our primary care pathway, we do a lot of education saying this is some of the information you are going to get back. and this is a treatment algorithm that can help you decide what to do. So I think that's been beneficial as well, some outreach and educational opportunities for our primary care providers and our health system. It is a lot of work. It's not easy, but I think all of us are more aware of these. As you've said, it's not just simply LDL reduction. There's so many other therapies that patients can benefit from. But we've kind of tackled getting the message out there in a multitude of ways.
Okay, well, that's just really important because usually you order a test, you get a result. But now that message of what you do with it, it's not just, it's a lot of people that need to hear that result. So communicating that is important, including with the patient. Okay, so we have a question here in our chat. In your view, is plaque analysis reproducible? And does it meaningfully support patient therapy within today's standard of care? Um, and there's a question of which of these medications are guidelines supported and covered by payers. So a lot to unpack in this question here, but maybe you can start with the reproducibility. If we send the same scan and it was to be reanalyzed by the next gen software, would we get the same results?
Yes, it's highly reproducible, and it was validated in the Reveal Plaque study, which showed very good agreement with IVUS. Basically, IVUS identified plaque. So when you look at how it was validated, as well as the tool has been used and its reproducibility, it's very high, to actually say the least on that.
Okay. I'll address the second part of that question about whether these are medications which are standards of care, and I would say yes, for high risk patients. Every one of the medications that was addressed here is I would say standard of care for a high risk patient that now has ASCVD. I would say even GLP-1 receptor agonists, if we think about trials like SELECT, which was done in non-diabetic individuals, that took individuals who had known coronary disease by virtue of an MI, or by virtue of having a prior stroke. But we are seeing now several studies, one from our group, another one from Johns Hopkins, showing that the more plaque and the more disease patients have on CT, the higher the risk, and they get to have a similar level of risk as the control arm of patients in the SELECT. Now, of course, in this particular case here, this was a patient with diabetes. So I think using a GLP-1 receptor agonist should already be standard of care. The reality is we don't use it for every patient that has diabetes. Really, the ones that we are most concerned, specifically concerned about cardiovascular risk. So I think that would be the reason to use Ozempic in this particular case, which should be covered. Certainly depends on plan. So I think we got those questions. I guess the next question here is this ever used for re-imaging to adjust medications? Maybe we can share. I would say that's still not something that's used widely as standard of care, but you can share with us your thoughts on that, Wes.
Yeah, I think there have been some recommendations out there in literature to consider that. I don't think it's prime time. I don't think most sites are doing that. We're involved with several studies looking at this, trials looking at that, but we're not routinely doing that. I think we probably will, and I'd love to hear your thoughts on that, Dr. Blanks. I think there will be a time when we do that, but we're routinely not doing it at Cone Health.
Yeah, no, I think you're right. I think there is going to be some movement in that direction. Obviously, we need more studies and more trials showing that those changes that we see are meaningful and that they lead to beneficial change. So my biggest piece of advice is only repeat a scan if you think it will result in changes in therapy. So if you're not maximizing everything and there's a concern that maybe there's other medications that would be implemented if plaque were to change, I think that would be one consideration. But certainly I think this is done on a very selected basis. We don't routinely just repeat coronary CTAs as of now. Certainly, as we have a technique like this that we can quantify plaque, this is a very hot area of investigation and something we may see more of in the future. All right, well, Wes, those are fantastic cases. Thank you so much for that. And we are going to move on to our next speaker. And great pleasure to introduce Dr. Brusha Parikh, who is an associate professor of medicine and cardiology and associate director of cardiac CT and also associate program director for the cardiovascular imaging fellowship, all at St. Francis Hospital and Heart Center in New York. Rusha, thank you so much for joining us. I'm looking forward to your cases.
Thank you, Ron, for the introduction, and thank you, SCCT, for having me here. So let's go over my case. So this is a 73-year-old male, BMI of 36, clinical presentation complaining of occasional shortness of breath. So does have a history of hypertension, hyperlipidemia, did have a previous cardiac evaluation about 10 plus years ago, doesn't exactly remember what test he had. Does have family a history of heart disease with his sister having shortness of breath and then after that receiving a stent. So, his breathlessness was concerning. Normal EF and, comorbidities, or when we talk about CAD, hypertension, hyperlipidemia, and obesity. So taking a look at his lab work, his total cholesterol was 154, triglycerides at 96, HDL at 61, LDL at 74, HbA1c at 5.8, and C-reactive protein at 0.2. In terms of his medications, he was on atorvastatin 20 milligrams, so very small dose, olmesartan 20 milligrams, and he was on ezetimibe Zetia 10 milligrams also for his cholesterol. And blood pressure was well controlled on the olmesartan. So he underwent a coronary CTA. So if you take a look at the top, calcium score was 398 with the left main score of 67, LAD calcification of 269, none in the left circumflex, and right coronary artery 62. And on the 3D rendering of the coronary tree, you can see the blue areas of calcification. So let's take a closer look at the coronary CT and the LAD. So you have that left main calcification from proximal to distal. You have that proximal LAD calcification. Let me get this video to play. But on the cross here. So just looking at these curved planar reformats and at different angles, you can see that calcification there. While going from scrolling from top to bottom on the cross sections, you can see that there's moderate stenosis in that proximal LAD. And this is just an image showing the heart flow roadmap for the right coronary artery. Again, we had seen, small amount of calcification based on the calcium score. And here these yellow capsules are showing 30 to 49% stenosis or, minimal stenosis here from these specks of calcification and some non-calcified plaque as well. So this is the interactive UI of the next generation plaque analysis. You can toggle around the 3D map. The yellow shows non-calcified plaque. The blue shows calcified plaque. You can go up and down the vessel. You can look at the corresponding cross sections. You can see the area stenosis, diameter stenosis of the vessel. You can toggle between the vessels. So now this is going through the right coronary artery, going up and down, seeing the areas of calcified, non-calcified plaque, similarly going through the left circumflex in the areas that were processed. And again, vessels larger than 1.8 millimeters are processed. So when we look at this patient as a whole, on the left, right below the coronary tree, you can see the total plaque summary was 334 millimeter cubes of total plaque volume, putting the patient at 42nd percentile, and it has the distribution of calcified, non-calcified, and low attenuation. So this is the PDF report that is generated for this patient. So again, total plaque volume, then you have the calcified at 40%, non-calcified at 60%. Again, when we looked at the CT for this patient, what was striking was all that calcified plaque. We tend to start missing the non-calcified plaque, or, we don't estimate it as much with visual assessment. Here, he didn't have any low attenuation plaque. And you can see on the 3D map, the distribution was essentially the LAD. RCA also has a lot of plaque, even though we just saw those small specks of calcification and one area of non-calcified plaque. You can see there's a lot of non-calcified plaque. So this patient we sent for FFRCT. So right coronary tree was normal, no hemodynamically significant stenosis. But let's take a closer look at the left system. So left system, the distal part, you have a value of 0.76. So 0.76 is borderline. More than 0.8 is normal. Less than 0.75 is positive, and 0.76 to 0.8 is what is borderline. When we have a borderline lesion, the couple of things that we start looking at, more carefully is get a value proximal to the stenosis. So in this case, proximal to where the stenosis starts, it's 0.84, just at the proximal LAD. Then take a value about 2 centimeters, 1 to 2 centimeters distal to the stenosis. So here it's 0.76. So now the second thing we look at is a delta FFR value. So what's the difference between the proximal and distal? So here the delta is 0.08. What is considered significant? So something more than 0.12 is significant. So this is a borderline value. And then when you look at the diagonal branch, you can see that the value goes from 0.75 to 0.72. Proximally, it's 0.76 at the ostium. So again, not a significant delta, but just a gradual taper. So let's see what happened next for this patient. So this referring decided to go ahead and do an invasive coronary angiogram. Again, the patient was very anxious given his sister's history. So invasive coronary angiogram, again, mild to moderate LAD stenosis on the angiogram. Invasive, so FFR was done invasively with, again, values ranging from 0.9 to 0.79. So again, a borderline value. So findings of the CT and CT-FFR were confirmed here. So this is a slide showing the DECIDE registry framework, and we'll see how our patient fits in. So total plaque summary was, 334 millimeter cubes. So that comes in the severe range. So summary of this case, we have CADRADS3 with the 50 to 69% proximal LAD stenosis, FFRCT values being borderline at 0.76 with the negative delta FFR value of 0.8, severe plaque volume of 334 with the distribution of non-calcified 60%, calcified 40%, low attenuation plaque 0%. So LDL goal for this patient was less than 55 milligram per deciliter from his value of 75. So the first change that happened was the patient was started on atorvastatin, increased from 20 to 80 milligrams. With his BMI of 36, he would be eligible and a good candidate for a GLP-1, though he did decline that pharmacotherapy and wanted to plan for just lifestyle modification. He did have a history of reflux and gastritis, and he's on omeprazole. He declined the aspirin as well. So we can open up for discussion.
Great. Well, thanks, Rusha. Really nice case. Also complementing here both the FFRCT and the plaque. Maybe we'll talk about the FFRCT. Certainly a challenging thing clinically when we have a borderline FFR value, whether it's FFRCT or same in the cath lab when the value is on the fence. So you walked us through really nicely on the use of the delta FFR, which we now, by the way, have in CADRADS 2.0. We have a whole section and a figure on how to use that. So this is something that is clinically used now for these borderline lesions. Do you use this routinely on all lesions or just borderline lesions? Tell us on how you use the delta FFR in your practice.
So we use it on definitely the borderline lesions, but this practice of being 1 to 2 centimeters distal, doing a proximal value and a distal value, we do use it on, look at it for all significant stenosis. The other area that we've been looking at is, when you have patients with very high risk plaque features, left main stenosis, sometimes, using that delta FFR value in those areas as well, though even when the FFRCT is negative. I know that hasn't been studied well, but there is some discussion regarding that.
Okay, so in this case, the delta FFR 0.08, so not quite significant. So ultimately, in this case, also had a cath that also had a borderline FFR. Ultimately, this patient managed conservatively, no PCI. Okay, so patients managed conservatively. Let's talk about that. How do we treat this patient? So one of the things that this case shows right off the bat is our lack of excitement sometimes to intensify therapy. This patient, has some risk factors. LDL is 74 on atorvastatin. And the reality is most clinicians say, yeah, 74, that's pretty good. We'll leave that alone. But now we have plaque analysis, and now we see this patient has 344 cubic millimeters of plaque. 60% of it is non-calcified. It took that information to intensify lipid-lowering therapy. Are you seeing this a lot, that patients who are on statin therapy, people kind of keep the same doses? Nobody really wants to change that unless there's some real rationale for that?
I have seen that, and unfortunately, more than I'd like to. And that's where I think, the CT and the plaque analysis is really making a difference. You're putting other numbers besides the LDL. LDL goals have lowered over years, and, there's some people who still believe, it doesn't have to be as low as possible. And that's where having a plaque analysis, putting something in addition to the LDL is helping. And something as simple as, for this patient, he wanted a minimalistic approach to the medications, so something as simple as just intensifying atorvastatin, so going from 20 milligrams to the highest dose, and we'll see how he responds before escalating to the next step.
Okay. And possibly that next step, you certainly mentioned that there was some reluctance for being on a GLP-1 receptor agonist, and this patient was a BMI of 35 or so. So certainly discussing the specific cardiovascular benefit of that agent also comes to play. So hopefully, this is information that will help us not just lower LDL, but implement other aggressive therapy. So you showed us really nicely how you use the user interface, which I think is really nice. You can walk down the vessels and show folks where the plaque is. Are you using that in your clinic right now? Or are you using more of the PDF reports that kind of come with the cases?
So we've had a mix of both in terms of our referring. So again, as a part of Decide Registry, a lot of our clinicians have access to it. And I've asked around, and some still prefer to use the PDF versus the interactive is being used by a few. So it's been a mix. Both have been useful. Of course, I think the interactive is a much better representation and a way to show patients, but it also takes time to log in. So, understanding that, and, the volume of patients people see, and being respectful of that, I think both ways have been great teaching methods for patients.
Yeah, great. No, I think those are great points. Obviously, we all have shorter and shorter clinic slots. So bringing this information, there's always challenges, but I think it's so powerful to see pictures and or at the minimum here to see numbers. Here's how much plaque someone has. Great. Well, we've had 3 great cases, and I can't wait to see the 4th one. So walk us through that.
So let's go over the next case. So 60-year-old male, BMI of 29. His clinical presentation was, he is active, but intermittent discomfort in his chest while swimming. So past medical history of hypertension, hyperlipidemia, diabetes, also history of COVID-19. He is a active smoker, 1 pack per day for 25 years, and alcohol use. So this is his lab work. Total cholesterol 151, triglycerides on the higher side at 215, HDL of 54, LDL also 54, and ratio of 2.8. So his current medications: aspirin 81 milligrams, atorvastatin 10 milligrams, valsartan 320 milligrams, amlodipine 5 milligrams, He is on semaglutide 0.25, empagliflozin, 10 milligrams, metformin, and insulin. So he underwent a coronary CT with a total calcium score of 405, a calcium score distributed from his left main to his LAD predominantly, and a little bit in his right coronary artery. When we look at the CPR of his LAD in the center, and I've highlighted with the yellow box the area most concerning, you can really see that calcified and non-calcified atherosclerotic plaque. Again, just even visually, you can see the high risk features with the positive remodeling, the spot of calcification in that non-calcified plaque. So let's take a look at what our plaque analysis tool showed. So here I'm just including still shots, but total plaque summary showed 275 at 82nd percentile. Again, this is a 60-year-old patient with calcified at 24%, non-calcified at 76%, and also with low attenuation plaque. So the first cross-section shows the left main, just ostial left main. You can see the low attenuation plaque right there within the non-calcified plaque. The next is that high-risk plaque lesion that we were seeing with the positive remodeling, the spotty calcification. But here, interestingly, you can see those two purple pink dots in the middle of the non-calcified plaque, which is the low attenuation plaque. So here again, it was identified as 50 to 69% stenosis. You can see in the center of the straightened CPRs where LAD, the FFRCT value shown for that point, but stenosis is 50 to 69%. It tells you how far it is from the ostium in case, you were planning for a PCI as well and using this tool. So FFRCT was performed for this patient, and here you can see it was not hemodynamically significant. So you have a value of 0.94 distal to that proximal stenosis. So again, with the high-risk plaque features and the patient with his vague symptoms, this patient and the proximal LAD involvement, this patient also underwent an invasive coronary angiogram, and it showed, around 50% proximal LAD stenosis that was decided to be managed medically. So for this patient, again, decide registry, the algorithm framework. Let's take a look where our patient lies. So we have a CAD-RADS 3 with the 50 to 69% proximal LAD stenosis, HRP positive, so had two high-risk plaque features, so positive for that. FFRCT negative, so if you think about CAD-RADS 3, it's going to be HRP positive, I negative. Has severe plaque volume with the 275 millimeter cube at 82nd percentile, non-calcified being 76%, and with low attenuation plaque of 1% and calcified of 24%. LDL goal for this patient is less than 55 if you look at the DECIDE registry, but he was already less than that. For medication, so this patient, statin therapy was escalated, atorvastatin to 40 milligrams, and LDL dropped to 24 milligrams. So again, this patient, a more minimalistic approach was taken where the LDL did drop. However, triglycerides initially were on the higher side, also gradually dropped to 118. LDL dropped to 24. So this is my case. We can open up for discussion.
Great. Well, that was a really beautiful case. I mean, a tough case clinically, right? We have a moderate stenosis in the prox LAD. We always have healthy respect for the proximal LAD. You showed us on the cath, I'd say, well, yeah, there's some stenosis, but then you show the CT, and now I'm even more concerned because I see high-risk plaque characteristics, positive remodeling. You showed us low attenuation plaque. So certainly we are concerned about high-risk plaque. So certainly one question is, we intervene on this, and the FFRCT was negative, a non-flow limiting lesion that nevertheless has high-risk plaque. So I guess you made the decision to treat aggressively in this case. LDL is already not too bad, but now that you know this information, you'll go even lower. Talk to us a little bit about this challenge here of having an FFRCT lesion, but you still have high risk plaque. I know we don't have a lot of data. Maybe you can point to that, but what is the challenge in the field right now for lesions like this?
So I think when we're looking at FFRCT, we're looking at, what is the immediate risk of this patient in terms of having an MI, and that's where it's low. But when we're looking at plaque and high risk plaque, we're looking more at, what is the long-term risk of this patient? And that's where it increases unless, we have intensified medical therapy or, I think that's where what we're looking at, we don't have enough data yet.
Okay. We have, why don't we have Wes join us as well? We'll just spend the last couple of minutes on the discussion. You both showed FFR cases. We talked about the fact that FFR is really on a continuum. It's not a binary yes or no. So one of the questions in the chat, is some other method use binary ischemia, yes or no. Is that useful in your opinion? Tell us how you think about ischemia, yes or no, versus on a continuum gradient.
So yeah, I can comment on that. I mean, I think the Heartflow FFRCT tool giving you kind of a continuous, data points to look at is meaningful to me. Our site's very well versed in that, and we're able to use it. I think it's nice to be able to go and look and see, as Dr. Parik's case has shown, where that value is, how distal to that stenosis is it. And I think that's very meaningful in practice. I don't really know if a binary outcome for ischemia would be that helpful, especially when you're able to look at as the flow down the tree reduces, kind of what you're dealing with, because you may be dealing with a distal vessel that's not significant or just tapering artifact. So to me, it's more valuable to have the continuous data points.
Okay, great. Anything to add, Rush, on that?
No, I think, similarly, each case is different. You have sequential lesions at a lot of times, and just having positive ischemia doesn't always mean, it's something intervenable. And that's where putting some context of, where the FFRCT is, what the delta is, things like that are of benefit.
Okay. There's a question in the chat about how plaque compares between different vendors, and certainly, the goal of our webinar is not to talk about differences between all the vendors, but I still think there's an important point there. If you are going to check plaque and repeat that and say what happens to plaque, there are differences. There's differences in validation. There's differences in technique. So it is important to use the same vendor. So just to answer that question that's in the chat, you would never want to take patient and subject them to different types of analyses by different vendors, because I think it's going to be very difficult to know how to put those numbers together. Another question here is, who's primarily using plaque analysis, radiologists or cardiologists? Yeah, I thought at SCCT we don't get those questions anymore because everyone knows it's both. But why don't you guys give us your thoughts on this? And it's also part of that question, are PCPs ready for assimilating this into patient management? So maybe I'll ask you that easier question, Wes. You talk a lot about how you interface with your PCPs. Are they ready to tackle this, to get reports on plaque and to be told, here's what you need to do? How do PCPs receive this information?
Yeah, I think the bigger question at our site was, are PCPs ready for coronary CTA in general? When you look at, the shortage of cardiologists that's going to occur over the coming decades, it's here now, shortage of providers, wait time to see a cardiologist for referrals are longer and longer. So I think that's kind of what led to certain primary care providers reaching out to our group to say, hey, do we really need to wait for them to see you in the office to order the CT scan? So that led to kind of a pathway. I think it's to be determined. I think it is a lot of information, as you said. How do you incorporate that in? But I think the nice thing about the DECIDE algorithm is it's simple. And I think clinicians, for better or for worse, are more likely to adopt simple pathways. So I think they possibly are. Now, it's probably going to be a lot of co-management. That's kind of what we're seeing. But I do think they're ready to order the test in general. And then if you order at our site, you're going to get this information back. So, a lot of co-management will probably occur after.
Okay, no, I think great points, and certainly areas that we need to educate everyone on this. This is a new tool. We're gonna have more and more data. We need to educate not just our primary care doctors, but a lot of our referring cardiologists. Rusha, how do you educate all your referring physicians on this? Do they call you all the time? They must be calling you to say, what do I do if this patient has 233 cubic millimeters of plaque? What should I do?
I think a lot of it has been really educating and, showing them pictures, showing them the PDFs or, interact, like sometimes just taking videos of the interactive plaque module and sending it out to them and showing them what to do. And, right now we've been using the Decide Registry as a framework of, recommendations of what to do next. But it always comes back to, shared decision making with the patient. And I think my two cases were examples of that, where, we would have liked to escalate much more, but we also have to work with what the patient's willing to do and kind of go, somewhere in between.
Yeah.
But
No,
we have a lot of education to do with patients and with referrings.
yeah. No, I think we are in an era that patients, have a lot of different thoughts, a lot of different preferences when it comes to therapy, but also they want to make the best decisions. So data is important, especially if it's good data that helps make decisions. And ultimately, I think patients think very differently about this information, and we all have to meet them where they are with respect to how aggressive to be. But the more information we can bring into the discussion, the better decisions we can make together with our patients. So I think at the end of the day, this is, a tool that gives us more data to hopefully make better decisions for our patients. If I were to really simplify things. Great. Wes and Rusha, are there any other kind of final thoughts as we end that either by observing each other cases or anything else in our discussion today that you want to leave our audience with?
I think one of the points brought up is, repeat imaging and where we're going. The one plugin I did have is, as we're progressing with newer technology, we're bringing down the radiation doses significantly for testing, at least with CT. And while there's not much data, but, it is something out there. The way we've seen patients have repeated, nuclear tests or stress echoes. Stress echo, of course, is without radiation, but that is something, that can be done. And now we have plaque analysis where we can objectively look at, the amount of plaque, non-calcified plaque, high risk plaque, low attenuation plaque. So I think, that's there, and that might be where we're headed towards.
Yeah, I think those are all great points, Risha. I think some of the keys for the field right now is establishing what is if someone's plaque progresses, what amount of plaque actually qualifies as a progression, what amount of reduction in plaque qualifies as a regression, and I at least tell all my patients that if your plaque doesn't change and everything is the same, that's actually usually a win, because our goal for most of our patients is to keep the amount of plaque where it is, so it doesn't progress over time and it doesn't become unstable. So I think we have to kind of decide what that is. And we also have to be realistic, because I think we all get questions all the time when we talk about plaque. And I always tell folks the most common question is, how do you make that plaque go away? How do you melt it all away? And we have to be realistic that we are unable to do that. But if we can stop the progression, or if we keep it where it is, that can be very beneficial. So Wes, what are some of your final parting thoughts for our audience?
Yeah, I think the plaque analysis is just moving towards a precision pathway for prevention. I really think we're really able to target patients in a more meaningful way, and probably improve outcomes in a more meaningful way. I know there's a lot of data that's going to need to be collected, but overall, I think it's just moving the needle to a more precision pathway for patients.
Okay, and we have one more question here in the chat. We actually had more than one question here on the payment. Who's paying for this? That's always an important thing. So we thought we would show this slide here at the end to answer that question. So as of now, 5 of the 7 Medicare administrative contractors actually published coverage determination as part of LCD for AI coronary plaque analysis. So you can see that on the screen here. And also, just recently, several private payers have also came up with policies. You can see some of them listed on the slide here. Avicor, United Health, Cigna, and Highmark. So the fact that we have commercial payers who are now have guidelines for this and payment for this when performed under those guidelines, I think is really important for the field. So with that, I want to thank Wes and Rusha. They presented fantastic cases, as I knew they would. And we had a really nice discussion of how to use plaque analysis to decide on medical therapy. We also had some nice cases of FFRCT in different scenarios. This was the second part webinar. So if you've not watched part one, please go back and do so, because that was also a wonderful webinar. And with that, I will conclude. Thank you all.